Good morning, everyone. So, today we're going to answer a question that I get all the time in the clinic and on intake calls, and when I speak about ketamine to patients and actually providers as well. Everyone wants to know, what do you actually feel while you're going through ketamine treatments? So, I always tell patients and providers and whoever's asking, first and foremost, I personally do not have experience with ketamine myself. We were trained way back when. You do not mess with your medications that you provide to patients. That is patient use. So I've always been trained in that mindset of, you don't get high on your own supply. So we do not, we used to not at all even go there, if you will. But now, actually, and interestingly enough, it seems that, kind of that experiential training for especially a lot of therapists is really to go to go through the experience themselves, because then they really know what their patients are feeling as well. But to be honest, there is actually an issue with that, and that is that some research has shown that ketamine doesn't work the same way in a brain that is has had chronic depression, anxiety, mood disorder versus a brain that does not have those chronic illnesses. So the drug itself seems to actually have different effects. But having said that, the dissociation that occurs with ketamine, and it really is a dissociative drug, just to kind of put things in perspective, it's not necessarily a hallucinating drug. It's more what we consider to be a dissociating drug, and I'll get to that here in a moment. But generally speaking, we do see that whether people are coming in, providers are coming in that have no mental health diagnoses and just want to see what ketamine feels like for them, as opposed to our patients. It does seem that both groups experience dissociation. So then it brings us back to the question of, well, what is dissociation? What does one feel when one is going through a ketamine experience, whether it's nasal, Spravato, or the IV infusions? And so really what's happening with ketamine is there's a dissociation, if you will, between the limbic and the cortical systems. So what does that mean in English? Well, the limbic system is the part of your brain that is involved with behavior and emotional responses. And there are a lot of structures within that limbic system, and those are actually buried deep in the brain. They are underneath the cerebral cortex, which is the upward layer of the brain, but they're above the brain stem. So they sit between the brain stem and the cortex, kind of deep in the brain. There are several structures that make up the limbic system, if you will. The two major structures are the hippocampus, which is involved in memory consolidation, building memories, whether it's episodic memory or long-term memory. Episodic meaning short-term memory. So, you have your grocery list that has 5 things. You try to remember it. You go to the grocery store, and hopefully you still do. Or, that's an episodic memory. Or, if you're encoding for longer-term memories. And then the other structure is the amygdala. And the amygdala, excuse me, is responsible for feelings and emotions like pleasure, fear, anxiety, anger. So both pleasant and unpleasant emotions. And then there are other structures that make up the limbic system as well. The thalamus, the hypothalamus, which is very important for hormones that regulate thirst, mood, stress responses, hunger. So that's the hypothalamus. And then it also encompasses the basal ganglia, which is actually where reward processing occurs, habit formations, movement, and learning. So these are all structures that are also involved in the actions of the limbic system. But having said that, the two main structures, again, are the hippocampus involved in memory and the amygdala, which is responsible for feelings and emotions. So that's the limbic system. Your cortical system is, again, that outer layer of the brain, closest to your skull, if you will. And the cortical system is involved with controlling memory, your thinking, your learning. It's really involved a lot with reasoning, problem solving, emotions as well to some extent, and then consciousness. So that's that outer layer or the cortical system. The cortical system is extremely important because it also processes information from the five senses. So your sight, your hearing, touch, taste, and smell, right? So it is responsible for information coming into you from your sensory organs, so that when you touch something, you're like, oh, that's cold, or oh, that's temperate, or oh, that's warm. That's all being processed through the cortical system. It also does control your social skills and language as well. So when ketamine is provided in a sub-anesthetic dose or in microdosing, like we do at Avesta with the IV or with the Spravato with the nasal, what we're basically causing is a functional and electrophysiological dissociation between the thalamo, neocortical, and limbic systems. So, in other words, the sensory inputs may reach cortical receiving areas. So, you're still sensing the music that we ask you to bring with you. You're still sensing temperature. You're still sensing things visually, but you fail to observe them in some of the association areas. So what ends up happening is that there is kind of an impression of unreality or a floating, or even what we call depersonalization or conscious dreaming is how people experience it. And so interestingly enough, there is a scale that scientists have used, psychologists, basic scientists have used. It's called the Clinician Administered Dissociative State Scale. So it basically are a set of questions that we can ask individuals that are undergoing dissociative medication like ketamine to ascertain whether they are truly dissociated. So examples of questions might be, do things seem to be moving in slow motion? Is the when you are experiencing ketamine, does it feel like things are coming at you in very slow motion? Do things seem unreal to you, like they're happening, but you feel like as if you're in a dream? Or do you have some experience that separates you almost from what's happening? For instance, do you feel like you're in a play or in a movie, or as if you're a robot, like you're just not in this reality, you're in a different reality? Or do you feel as if you're looking at things from outside of your body? And we get this a lot. Patients say, well, I felt like I was in the corner observing myself, watching myself. Or do you feel as if you're watching the situation as an observer or a spectator? So same thing, it feels as if you're kind of out there in the corner of the room and you're observing your own self. And then another one is actually feeling disconnected even from your body. So we actually ask, do you feel disconnected from your own body? And so the answer tends to be yes to a lot of those questions, that patients feel robotic or they feel very slow. Another effect of ketamine actually is kind of a loss of your temporal senses. So people feel like time has moved really fast or time has moved really slow. Patients get their ketamine and all of a sudden, the infusion, and it's been 45 minutes. We stop the infusion and they're like, wait, is it over? I didn't realize it's only been a few minutes. And it's like, no, it's actually been 45 minutes. So that's, I hope, helps explain dissociation a little bit. But really, at the end of the day, I think the best people to explain what dissociation is, an individual that we use a lot in the clinic to help patients integrate what's happening in this dissociative state. So I'm now going to turn the table over to my colleague, Naomi, who is a coach and is involved with patients in helping them integrate, helping them set intentions, and has sat with a lot of patients as they experience ketamine. So, with that, I'm going to stop and turn the table over to Naomi.
Thank you, Dr. Shkavari. I really appreciate all of that input, and it's to me so interesting to hear how ketamine works in the brain, and I hope everyone else feels that way as well. Um, so now, Naomi, I'm going to give you the stage, and she's going to speak briefly about the kind of work she does with patients to make sure they're prepared for the ketamine experience. And afterwards, like I said before, we'll move into the Q&A segment where they will both answer questions about what ketamine feels like and any other questions you guys have based on their experiences with patients. So hopefully that I'm excited to hear what Naomi has to say, and I'm excited to move into the Q&A segment.
Hi, thank you, Stephanie. Hello, everyone. My name is Naomi. I am the psychedelic integration coach at Avesta. Today, in addition to talking to you about what ketamine feels like, I want to speak to you about something that often gets overlooked during the psychedelic healing process, and that's integration coaching, especially when working with ketamine. Over the last few years, I've watched people go through ketamine journeys, and what I've seen has been profound. People confronting long buried grief, reconnecting with self compassion, letting go of shame, rediscovering purpose. But what determines whether those experiences lead to lasting change is not ketamine alone, it's what happens around the experience. And that's where coaching comes in. So let's begin with what integration coaching is. It's not therapy and it's not advice giving. It's a grounded, compassionate relationship that supports you through the arc of your ketamine experience before, during, and after. The arc is usually made up of three key sessions: the preparation video call, the in person sitting session, and the integration video call. Let me briefly walk you through these. The preparation call is where the journey begins. Before you even take ketamine, we meet virtually to set intentions. We talk about your story, your goals. We meet virtually to set intentions, talk about your excuse me. We talk about your story, your goals, your fears, your hopes. We discuss how ketamine works, what to expect, and what to do if the unexpected things arise, emotionally, physically, spiritually. It's a time to get clear on what you're bringing into the medicine space. Um, but it's more than just logistics. The prep call creates trust. It helps you feel safe going into the unknown. Ketamine is not a typical medication. It opens you up, it softens your ego defenses. And when that happens, anything can arise. Childhood wounds, hidden truths, long lost creativity. If you go in feeling prepared, grounded, and supported, you're more likely to go in and receive what's there for you. The sitting session. This is when you're in the ketamine session itself. This is where the coach is physically there with you in the clinic, offering light support and guidance as needed. I've watched people shift dramatically just because someone was there with them. A calm and grounded, non-judging, not interrupting, just witnessing. That presence provides safety, knowing you're not alone, helps the nervous system relax, gives people permission to let the medicine do its work. The feelings that arise during ketamine are often indescribable: a floating sense of self, a disconnection from time, a sudden encounter with joy, grief, or God. And yes, sometimes it's disorienting. Sometimes people cry. Sometimes they laugh. The coaching provides a held container for whatever comes up in the session. And from watching people go through it, I can say ketamine can bring a deep sense of emotional clarity. People often come out saying, I finally felt that part of myself, or now I understand what I need to heal. It's like the defenses drop, the inner truth steps forward. The medicine creates a window, but the sitting session gives that window a frame it needs to feel safe. Next is the video integration call for clients who choose to do an integration call with me a day or two later. We meet virtually. This is where the thread comes together. We walk through the journey, what came up, what stood out, what does it mean to you? And most importantly, how can you bring this into your life? Without some type of integration or follow-up with your therapist, even the most beautiful ketamine journey can fade into memory. But when you talk it out, reflect on it, write about it, or even create from it, the experience takes a root. It starts to change how you relate to your body, your relationships, your habits, your work, and your inner voice. Integration coaching turns the experience into transformation. So, what do people actually get from coaching? They get clarity, they get safety, they get accountability, they get a mirror that they might otherwise miss. They learn how to trust their own inner wisdom, and maybe most importantly, they feel held. That sometimes I've seen time and time again, the real healing doesn't just come from ketamine, it comes from truly feeling supported during the most vulnerable moments of someone's life. Coaching makes sure that the journey doesn't end when the session does. It helps people step back into their life with new eyes, new strength, and new intention. Ketamine opens the door. The integration coaching helps you walk through it, stay grounded, and make the path your own. Thank you.
Thank you, Naomi. Um, and I talk to so many of our patients that work with you and that don't work with you, and everybody just has so many good things to say about you and how grounded you make them feel during the experiences. So that, I mean, what you just said, really knowing how you work with patients and how the patients respond, it is really cool to hear you speak about that, and it's really cool to see patients work with you and get better and feel comfortable with the dissociative experience, which is such a big experience. Okay, so we have gotten a good amount of questions. So we'll now move into the Q&A portion. And I don't know if I'll just ask both of you. A couple of them are directed to either of you, so I'll tell you when. Um, so Naomi, can you describe how dissociation usually presents in your patients?
Sure. The first thing that I notice is a sense of relaxation in the face. People, especially for our first ketamine experience, they tend to be pretty anxious. Um, the relaxation in the face comes, the breathing changes, where it's softening the breath. Um, People feel lighter. They'll describe to me in the beginning, they can talk, typically pretty easily in the beginning of it, and they'll describe themselves. Their body feels really heavy, or their head feels really light and in the clouds, is what they're describing. Almost a euphoric feeling in the beginning, and it changes as the ketamine progresses throughout the infusion.
Okay, let's see. Also, Naomi, what does the right set and setting for the experience mean to you?
To me, well, in the clinic, the setting is already established. We have, we provide quite a bit of comfort in the clinic. There's nice, comfy lounge chairs and blankets and things like, around you physically. But what I provide and what I try to help other people, even if they just do a prep call with me and not an actual sitting session, is just that grounding, setting up the experience of doing some breath work, doing some meditation beforehand, doing some journaling, is part of the setting when you go into the clinic. And just trying to connect with the providers that are there, because that can provide comfort in itself when you're undergoing a ketamine infusion.
Okay. Dr. Ashkavari, does ketamine help with amygdala hijacks? I'm not completely sure what that
Right.
is, but
I don't know what that is either, but just having described the effect of ketamine on the brain, yes, there are lots and lots of glutamate and AMPA receptors at the amygdala, and what their role really is a little different. The the AMPA receptors do respond to glutamate, and really what they're doing in the amygdala is helping reform memories and emotions around memories. So there is a lot of work that's done at the amygdala after a ketamine infusion. We usually see the areas light up in humans about, I would say, 12 to 24 hours after the infusion. And that's why we always tell patients, it's really helpful to do integration work either with Naomi or your own therapist a day or two after the ketamine. So I don't know what amygdala hijacking means, but there are certainly AMPA receptors in the amygdala, really prevalent actually, which is involved with memory consolidation and especially fear-based memories. And that's where we hope that the ketamine really impacts those AMPA receptors to cause neuroplasticity, specifically in those areas of the brain, one of which is the amygdala.
Okay, thank you. Either of you, I guess, how does the ketamine dissociation help with patient healing?
I'll let Naomi answer that one because to me, I rely more on the what happens after in the brain at the receptors. I think Naomi can speak probably a lot more to kind of that healing that happens during that dissociation, which can be very helpful. So Naomi, you take it away.
Sure. The dissociation helps someone look at their life from a different perspective, point blank, right there. Like they can look at their life from a third party perspective. When you're in a dissociative state, one example is you're like in a room inside your head. Some people are able to engage and ask questions to themselves and answer the questions for themselves, or they're able to look down at their life and see what's going on for them and kind of have a different perspective of actual actions that are happening in their life or things that they're saying to themselves. They can see how they feel when they say that to themselves from a different perspective. So the dissociation, can create, ultimately just that different perspective is what I see from time to time that helps create the healing. It creates a different sense of emotions that are going on in the body about, when they're viewing their life from a different perspective.
Dr. E, do different administration routes, so IV, IM, troche, lead to different feelings?
I'm not sure if they lead to different feelings, but I would imagine that of the three, because when you do the IV, you're getting almost 100% of the drug at the effect site, the brain, that it's more intense. So I would imagine that, in terms of ranking, the intensity is probably highest with IV, then IM, then the troches. But that is very dose dependent. So you could possibly give someone enough of a troche to get the same intensity as IV. But the problem with that is that if the patient feels like it's way too intense, which can occasionally occur, um, then there's nothing you can do about it because the patient's already ingested it. It's the same thing with the intramuscular. You have very little control. Whereas with the IV, if the patient feels like it's a little intense, we can just come in, stop it or slow it down, sit with the patient, reassure them that this is just part of the effect of the med. It'll wear off. It doesn't have any untoward effect per se in the brain. In fact, there's a lot of glutamate that's produced at that time, which can eventually be helpful, but in the moment it can be quite intense. So the feeling depends. The route will make a difference, but so does the dose.
One other point to make is that when you have intramuscular, the intensity shoots up very quickly and then you come down fairly quickly. When you do it with the infusion, it's almost like a bell curve. You go up slowly, you plateau, and then you slowly come down. It's not a milder feeling, but it's a more pleasant experience versus shooting up, having the intramuscular. You feel the intensity for a brief period of time, and then you come down.
Yeah, that's a really good point, Naomi. And in fact, in anesthesia training, I don't know if anyone on the call is another anesthesia provider, but at the end of the day, in anesthesia training, they actually teach us never to use intramuscular ketamine. We only used to use it for patients who weren't cooperative, so who didn't understand that we wanted to start an IV to do the anesthesia. So what we would do is we used to call it a ketamine dart. We would give that patient an IM ketamine so that they'd be more subdued. And then we would proceed with the anesthesia. That's the only time when we ever did intramuscular, or if you're doing veterinary medicine where, you give the pet an intramuscular ketamine. It really wasn't recommended in humans, at least not in anesthesia. But I do think that, nowadays, because people don't want to set up a whole IV clinic, that some providers are doing intramuscular. So that is a way to get the ketamine. It's, to me, not the best way and not the most, as Naomi said, smooth way to get the experience.
Okay, Naomi, can you give an example of a patient transformation that you have seen through ketamine?
Sure, sure. Um, I like to look at that as, in a spectrum, because I have, recently I have like a 23-year-old and I have someone who's in their 70s. And I like to give that example to show the contrast of what happens in different ages. Both of them came in presenting with suicidal ideation and really some deep depression, feeling really stuck in their life. Similarly, both of them had great reactions on their first infusions, feeling really connected to themselves. The biggest thing I see is that sense of gratitude and appreciation for their life, allowing their brain and their thoughts to slow down enough to feel emotions and kind of review memories that feel meaningful in their lives. Noticeably, after they have gone through the treatments, the 23-year-old is now looking for a job. His executive functioning skills have increased. His social skills, not social skills, but just the the desire to go out and socialize with friends and be around people has significantly increased for that person. Coming in just feeling like I can go to therapy now. I want to go to therapy now with my therapist. I want to engage with my family. The older man was estranged from his daughter, feeling really depressed about his stage in life. Came in feeling like I want to move into a retirement community and be around people, and I want to engage in activities and go to dance class and start swimming. It really created a feeling of like I am connected to other people, and it was just a beautiful thing to see that he was feeling like my life's not over. I can still engage with people, and it was just very a beautiful experience to be able to see someone go through and then just help them feel comfortable and safe during the experience.
Naomi, you just made my day.
Mhm.
Every day I find purpose in this work, and that's right there. You hit the nail on the head. Yep.
Yeah, it's beautiful. Thank you.
Yeah, that's one of the
Great
most
question, by the way. What a great question.
a good
Yeah.
question. Um, okay, another one for either of you. Do trauma patients have a harder time with the dissociation? Like, do more things come up for them? That
Go ahead and repeat that question. I was
it says,
sorry.
do trauma patients have a harder time with the dissociation? Do more things, so I guess like more memories, come up for them?
Oh, that's a great question. I the trauma can come up. And that's, integration coaching does help in that sense where they need to be reminded that they're safe, need to be reminded that these are just memories. I have, a list of things that I'll repeat and how to support someone through that process. And it's different for each person. Some people don't experience their trauma over again. They can look at it from that third party perspective I had mentioned earlier and feel like, oh, that's not a part of my life anymore, and I choose to let that go. I'm going to choose not to go back to that experience because it how I've reacted to it now in my life isn't serving me anymore, and I want to move past it. So we go with what happens during the experience. Some people will experience it over again, and then other people will review it as a point in their life that they learn from. And that is really dependent on the person. I think that the experience helps people make sense of their trauma and decide what they want to do with moving forward with it, how they're ready to process it.
Yeah.
If that makes
I
any
think,
sense.
Naomi, you really raised a very good point about ensuring that not just PTSD patients, but really every patient feels like they're in a safe place. And that's, I really like to remind people of that, that I always tell patients, you're not paying, the fees that you're paying is really for me to do the worrying, and you know that you're in a safe place and that I'm going to take care of you. You're not paying for the ketamine. Ketamine itself is super cheap. It went off patent many years ago, so you're not really paying for that. What you're really paying for is the monitoring and the safe environment that you're in. And I think that becomes really important, whether the patient has a history of PTSD or not, just knowing that we're going to hold a very safe space for you, so that you can do the work. And I always admire patients that are doing this work because it's not easy. Patients every day tell me, I don't know how people do this recreationally, because it's not one of the fun drugs. It really does help you tap into a lot of different emotions and memories. And sometimes, yes, it can be that the PTSD, emotions, even if not the memories, but the emotions with it do come out. And that's why integration is so important.
In the process, if those emotions do come out, I try to encourage those emotions, and I try to help people feel like they're supported. But there is those times where someone will say to me in the experience, I don't want to go through this. I don't, meaning the memories. And I can, I oftentimes will walk them through a guided meditation, and through, like, I'll always ask someone, where's your favorite place? What's your Zen place? So there are ways to help someone in baby steps to go through these experiences, so they can understand that if it does come up for them and they're not ready to visit the things that they don't want to see, there are ways to help you through that process as well.
That's great.
Who are the best clients for ketamine therapy?
I'll tell you who's not great, and then that'll kind of narrow it down. So we usually don't recommend ketamine for patients who are in the manic phase of bipolar disorder. We also don't recommend it for anyone who has a history of psychosis, because it can make it worse. It can actually cause some of those. It does not cause psychosis on its own, but if you're prone to that, we just always want to be safe and mindful to not provide it to patients who have that history of severe psychotic episodes. And then we really don't recommend it for patients who have schizophrenia or schizotype disorder. So those are the patients that are not good candidates in Avesta's point of view, in terms of receiving ketamine. I think all the other diagnoses generally do well. We are very okay with treating teenagers. I know a lot of clinics don't. I've been giving people ketamine for over 30 years, and we generally use it in kids, so it's very safe. And so we are not, we don't make the determination that you are not a good candidate unless you have one of those diagnoses.
How often do people need the treatment?
Oh, that's like, if I had the answer to that question, I would be so happy. So it is truly very individual. It really is. It does take a good 6 to 8 initial consecutive treatments to really get patients to have that neuroplasticity. As you can imagine, we're causing new neurons to grow or new synapses to connect. And so that takes time. It takes us to intently come after those receptors repeatedly in succession. But if you are, I think if you are, past that 6 to 8, you're doing great. Then we start to taper you off slowly. And by that, what that looks like, that's the part that's very individual. So I have patients who do the first 6 to 8, they do great. And, we have them go to weekly for a couple of weeks, then every other week, then go to monthly. I really do want people to stay on a monthly regimen for at least 5 to 6 months. I really do, because people will backslide in that 6 month period if we don't. And then from there, we just tell patients, okay, if you're doing well with monthly, let's start to really extend to every 2 to 3 months. And from there to boosters. So generally speaking, that's what we've done for a long time. But back in November of 2023, there was a study that was published that actually demonstrated that the way we've been doing it at Avesta, meaning that we tapering people off slowly, works the best. And the same holds true for Spravato. We do the Spravato treatments. That protocol is very stringent, that we do it, 8 times for the induction. And then from there, you can do another couple if you don't respond, so we can push it to 10 to 12. But then after that, we should really start to extend time between visits to weekly, and then every other week, and every third or fourth week. And then we also have and are working towards building a model, because insurance covers Spravato a lot better, for people for whom paying for the treatments is difficult, and we totally understand that. We, can build a model where you start out with the Spravato, then as you're going to maintenance, we can start to add some IV to really build on those receptors, so that you're not losing momentum. So there are lots of things that we can do to individualize that maintenance plan. So the initial phase is usually typical 6 to 8 with the IV, 8 to 10 with the Spravato, but then the maintenance is kind of what sets Avesta apart, in that we really do taper slowly. And we have had for many years, until the research came out and said, hey, the best way to keep people away is to taper slowly. And then, of course, once people are functional, we start talking about the importance of diet and exercise and therapy in maintaining that resilience that you're building with these new neurons.
For Naomi, how is a coaching session during an infusion? How is an infusion with coaching different than an infusion without coaching?
I think that it really depends on the person and how much support they need, or they think they need. There are people who come into these infusions and they have a heightened sense of anxiety before they even come into the infusion. They've got maybe a trauma background of feeling unsafe in their life. Those are maybe a good candidate for somebody to come sit with them. People who are coming in for less, traumatic reasons, and they feel less anxiety. They may not need the coaching support during the infusion. Does that answer your question? I'm trying to think of. Okay.
Yeah, I think so. Dr. Shkavari, were you going to say something?
Yeah, I was going to say, when we do intakes and I sign off on the consults, I usually recommend for patients who have more prevalence of anxiety to have a sitter, whether it's Naomi or inviting their therapist for the first couple of sessions, or even connecting on a televisit with their own therapist, so that they have that additional support. Of course, the Avesta team, the medical assistants and the nurse practitioners are all very well trained on providing as much comfort as possible. But of course, we're dealing with multiple patients at the same time. So that's why if a patient, the biggest difference, I think, is, to have that additional support, kind of an anchoring point, if you will, to the treatment if you suffer from anxiety. And I really think that Naomi and I are right on with one another on this. Whereas if you're more depressed, and more prevalence towards being depressed versus anxious, I think those patients do just fine with the support that Avesta provides without a sitting session. But I think if you are, very prone to anxiety or suffer from severe anxiety, it really is a different experience to have a sitter, whether it's Naomi or your own therapist present.
I think that if someone has depression, a prep session with their therapist or an integration coach might be a good way to prepare and set them up for the experience, and kind of have a good mindset coming into it so that, they can get the most out of their experience. Could be another way to look at it for, based on what someone's coming in for, they may need different services from their therapists.
Is there any risk of addiction, and what if somebody has a history of addiction?
Yeah, that's a really good question. So, ketamine is not addicting like the opioids or benzos, or really a lot of the ADHD medications that are amphetamine based. So they're not physically addicting. So if I give you ketamine for 6 months and then you feel better and we stop giving it to you, you're not going to have seizures, increased heart rate, sweating, all the things that come with opioid withdrawal or even alcohol use disorder or any of that. So physically, it's not addicting, but it can be habit forming. And so that's why we always recommend, we are of the mindset that the best way to do the ketamine is in a clinical setting with professionals. And we've treated lots of patients with substance use disorder. We don't write people off because they have substance use disorder. And in fact, we like to help those people get to the bottom of what is happening. We work very closely with their rehab providers, with their own therapists, with their psychiatrists to come up with a really good treatment plan for that patient. And so it can be habit forming. And that's why when you come to our clinic, we're very mindful of, okay, you've had 6 to 8, it's time to start going to a maintenance phase. How are you looking? How are you feeling? We really deploy some surveys, the PHQ-9, the BDI-2, the GAD-7, to kind of gather more and more information about how to start to build a maintenance phase so that you're not, using it habitually, you're using it for the purpose that it is meant for, which is to help you feel better and become much more functional.
Do patients on Spravato experience the same dissociation as patients on IV ketamine?
Naomi, have you sat with patients with Spravato?
I have. I do notice a difference. I believe, or I've noticed that people who go through Spravato treatments, they experience a dissociation fairly a little quicker, and it's not as deep as the infusion. When someone's getting an infusion, it lasts about 20 minutes. The dissociation starts at probably about 12 to 15 minutes in. Somebody's deeply dissociated, they'll stay that way for up until, almost until 5 minutes before the infusion is going to end. A Spravato treatment, typically someone's in the clinic for 2 hours. Depending on, I believe they have 2 to 3 sprays. And by the third spray, within a few minutes, they're starting to feel the dissociation, and then it fades, and it turns into a introspective phase, more so than the disassociation in the Spravato, that lasts longer than the infusion, from what I'm noticing with sitting with people.
Okay, and is it more intense or less intense with one of them?
From what I've seen, the Spravato is less intense than the infusions. If someone ever thinks that the infusions are too intense, the nurse practitioner comes in and they slow down the drip rate. With the Spravato, you're in it until it kind of fades. I have not seen someone have a really hard and uncomfortable experience during a Spravato treatment. It does present as a lighter experience.
A question for both of you. So, Naomi, what percent of patients do you see getting benefit from the infusions? And then Dr. E, can you answer that, but from a research perspective? So what % of patients does the research say ketamine helps?
Sure. For me, it feels like the percentage is a lot higher. I do, sometimes 4 to 5 sitting sessions a day. So I don't see the spectrum of all the clients at Avesta. From the people that I see, I can say since I've been at Avesta, there's probably been less than 10 people that have responded ideally the way they want. I would say over 95 to 98% of people respond in some way or another in the way that they're looking to achieve some sort of self-actualization, purpose, feeling meaningful, experiencing a lighter mood, more energy. Those types of things are typically happening, and for people it ranges whether someone's going to experience that in the beginning of their infusion. It typically happens after infusion 4, 5, and 6. So that will change for each person. I've definitely sat for a handful of people that their first infusion was really profound and meaningful, and then other people, don't get that until number 6. So with that, I mean, it varies and it's different, but I see a high percentage of people responding to ketamine, but I also don't see the amount of volume that Avesta gets in the clinic. So
Yeah, so there's no single research study that points to this is the % of people that respond, positively. So that's not really a thing. But what is a thing is the studies that show a significant difference, right? Like in this population that got placebo or Versed or some other drug, what's the comparison between that group and the ketamine group? Or what's the difference between the PHQ-9 or the BDI-2 between the day 0 of when the patient started and day 14 or 16 or 18 after completing the ketamine infusions? So there are lots and lots of studies now that have demonstrated that ketamine causes significant improvement in patients that suffer from major depressive disorder, anxiety, OCD. There are studies around PTSD as well. So we have a lot of data, which a lot of us are trying to use all of that data to continue to send it to centers for Medicare and Medicaid so that they can start to cover ketamine treatments, especially IVs. Spravato has already been approved, but we really are trying very hard, those of us that practice ketamine, to send our data to CMS so that we can really demonstrate that, look, there are all these studies. I mean, there was a study recently in JAMA last year that showed that ketamine is just as effective and more effective than really addressing pretty severe depression versus electroconvulsive therapy, which is all we've had when people have not improved. So all of those studies were really trying to consolidate and send to the FDA and CMS so that we are saying, look, the proof is in the pudding. There's lots of research. We at Avesta also did a research study that we published last year in Psychiatry Research, where we demonstrated the efficacy of ketamine in major depressive disorder. So I think we're all trying to send all of the data that's saying, hey, a big percentage of people, a large percentage of people have significant improvement, percent, if you will, significant improvement. And so let's start covering this amazing treatment by first CMS, and CMS really sets the standard so that insurance carriers will also start to cover it, because I think that's one of the mitigating steps for patients is that insurance is so spotty and doesn't really cover the treatments, and they can be expensive because providing an infusion in a clinical setting where we're hiring experts to monitor becomes an expensive endeavor. So, in terms of percent of patients, I would say at our clinic, our efficacy rate is probably in the age range of 16. I think our youngest was 15 to 70. Our efficacy rate is probably somewhere around 85-90% for mood disorders. For pain patients, it's a little bit less, but that's a whole other topic.
Okay, I think this is gonna be the last question, and I know there are more in the chat that we haven't gotten to. I'll compile them and put them in an email after this and send it to you guys. Because there are some good questions that I haven't gotten to ask. But the last one I'm gonna ask is what is the difference between integration with a coach and integration with a therapist?
Sure, I can answer that question. My main difference is a therapist is working on, the extent of whatever's going on with the person from childhood up until their life for now. I'm strictly working with someone to prepare them for their ketamine infusion, helping them with the infusion, and I'm helping them integrate their infusions. The integration may be, setting goals and kind of creating steps in their life to move forward. So I think the difference is that they're digging into more behavioral models. They're practicing, the looking at their life in a deeper sense as far as like going into childhood, and I only review those topics on the surface to help them have whatever is fresh in their mind, so that whatever's going to come up organically during the infusion will. So we go over those types of things briefly. I think things are much more in depth when you have therapy sessions with your therapist.
Okay, well, thank you guys both so much for being here, and thank you all for joining